first of all, welcome. Thank you for tuning in today. Appreciate you all taking your time to listen to this and get some good reminders. We also want to thank our program sponsors. Definitely couldn't do it without their support. So we'll go ahead and introduce myself first. Y'all may know me. I'm Jaeger Spratt. I use they, them pronouns. I am the Advocacy and Treatment Access Program Manager here at PHA. And we have with us today, Tonya.
Hi, I'm Tonya Zeiger. I am a registered respiratory therapist, but also a program coordinator for a pulmonary hypertension program in Jacksonville, Florida. I am kind of the do-all person for our area, so I have a little bit of knowledge about a whole lot of stuff. So I'm hoping to share some of that with you today.
Awesome. Thanks, Tonya. So just a little overview of what we'll get into. I'll give everybody those reminders for the dates of open enrollment and just some things to keep in mind as we head to that end of year time. Talking about how to choose a plan, just a reminder of where y'all can find some resources about insurance. Then I'll get into what's new for 2024, which I know there were definitely some questions that were submitted pre-webinar, so we'll talk about that. Get into figuring out drug coverage and kind of trying to open up that can of worms a little bit. And then, of course, I'll remind folks of the financial assistance resources, and then we'll move into the Q&A section. As we're going through all of this, please feel free to put any questions that you have in the Q&A box, and as we go along, we can kind of pause and take care of some of those questions. But then there will also be a dedicated time to get to more questions. But yeah, definitely as you think of questions, feel free to pop them in. So first off, this year's dates, they're pretty similar to last year. So the health insurance marketplace, that opens on November 1st. That's a Wednesday this year. The cutoff to get insurance that will start on January 1st. That cutoff is December 15th. But there are a lot of states that have extensions until January 1st or later. So, the December 15th isn't necessarily a hard deadline. It just means that your insurance coverage would be kicking in a little bit later than if you met that December 15th deadline. So you will want to check out what your specific state's deadlines are if you're getting insurance through the marketplace. And then for Medicare, that's the same as usual. So it actually has already started open enrollment. That started on Sunday, the 15th. And then that will close on Thursday, December 7th. So during this period, you can sign up for plans. Also, if you're in a Medicare Advantage plan, the first 3 months of the new year, you're able to switch between Medicare Advantage plans. You can also switch from Medicare Advantage back to original Medicare if you find that the plan that you had selected isn't meeting your needs like you thought it would. So there is a little bit of leeway, but the main open enrollment for Medicare is from October 15th through December 7th. And then for commercial plans, that's going to most commonly be through like an employer. Those ones are going to vary just by your company, whoever's kind of providing that plan. So your best bet is going to be just to check with your HR department to ask about what those open enrollment dates are. They do usually tend to be towards the end of the year, though. So this is still definitely the right time to be thinking about this. And then I'll turn it over to Tonya to give a couple other end of year reminders.
Okay, so the first thing I wanted to say is for employers, you definitely want to make sure that you're taking a look at what's provided for you, just like you would if you were Medicare. A lot of patients or a lot of people have Medicare supplement plans that are provided by their previous employers. We realize there's not much you can do about that. That is what it is. But it's always a really good idea to go ahead and just see if what you can find out in advance of that change. If you are looking at changing your Medicare or your plan, you definitely need to look at getting an additional refill for your medications by the end of the year. That's important because if you say are you're set for your regular medication prescription refill on, say, December 25th or 26th, your plan actually, your new plan will start on January 1st. If you end up, if you have to get your refill that last week, that's perfect. If for some reason you end up having your refill near the beginning of December, then come January 1, your team is going to need to get all new authorizations prior to your January shipment. In that case, it has delayed some people and their care because they've not been able to get their drugs in appropriate timeframes. So really be aware of when your last shipment is for the last of the year. The other thing is to really notify your entire care team when you are looking at changing plans. A lot of centers like ourselves end up going ahead and doing the next year's authorizations at the end of the year, and they will allow us to do that in many cases. What happens though, unfortunately, is we will go ahead and do all of that, get it all situated for our patient. And then we find out, the second week in January, oh no, I switched plans. So now we're kind of under the gun and having to really rush through and try to get everything so that you get what you need. That being the case, it's really important that you really look at the plan that you're looking at, see if they are on a calendar year from January 1 to December 31st, or if they work on a 365-day calendar. Another issue that we've run into in the past is that a patient will be on a plan that provided a 365-day rotation. So say your authorizations are all good until October of next year, then you find out, oh, wait, no, I still have to reapply, or I still have to have everything reauthorized January 1. Now what happens? Your entire year shifts. So those are kind of some little caveats that we've run into, issues that happen on a fairly regular basis in our department. So the next slide.
Yeah, definitely all good stuff to keep in mind, and just a fraction of why this time of year can be challenging. Thanks, Tonya. So I will go ahead and get into the choosing a healthcare plan section. So healthcare plans of all kinds offer an annual enrollment period during which you can add or change coverage without penalty. So this can be a pretty great opportunity to review just what kind of healthcare insurance options are available to you. It's a good time to prepare for any anticipated changes in your coverage needs for the coming year. If you happen to know that there's going to be a change like that, obviously we can't always anticipate those changes. Oh, let me go back one. So a good way to do this, you just want to start by gathering information about your plan options and making a list of each plan option that's available to you, just to kind of lay out all of those different potential things that you will be considering. So you'll start by listing out the medications that you take, any kind of medical care that you expect to need in the upcoming year, including routine tests and hospitalization. Then you'll want to figure out whether the plan choices available to you would include coverage for those prescription drugs, or if you would need to purchase that kind of coverage separately. You'll also want to take note of the premium or monthly cost for each option. You'll need to find out if any of the plan options require you to pay a deductible before coverage begins, and if so, you want to make sure you know how much that deductible would be. Then you'll review your list of anticipated medical needs and review the plan options just to determine whether those anticipated needs would be covered. So for example, would your PH medications included on the prescription formulary be covered? If they are on the formulary, or if they're not, that's kind of a separate thing that you have to discuss with your care team. You'll need to know if there's a limit on the number of nights that the nights in the hospital that the plan would cover. So just be sure to take note of kind of what portion of those costs of those items your plan would cover and what portion you would be responsible for. So like, for example, for each of your pH medications, you'll want to know if you would be charged a set dollar amount, which would be a copay, or if you would be responsible for a percentage of the drug price, which would be known as a coinsurance. So after gathering all of that information at this point, you want to compare the total cost of the plan options. So that would include like the premiums, as well as what you would have to pay out for the medication copays and other expected medical service needs. As a general rule, plans with more expensive premiums tend to cover more services, or they'll cover them at a higher rate, which can make them a better deal than lower premium plans if you're considering those total expected costs for the year, even if that premium cost each month is going to be higher. Finally, you do want to double check the information on your pharmacy network as well. Individuals with PH should definitely be paying special attention to their pharmacy network, because it is critical that you're going to be able to receive your medications through specific specialty pharmacies. Not all pharmacies are going to be able to provide those PH medications. And then for plans purchased on your state's insurance marketplace, when you're going through marketplace, there's 4 categories of health insurance plans. They're bronze, silver, gold, and platinum. So those categories show you how your plan and you are sharing those costs. So the lower premiums correlate to higher rates of cost sharing. But those plan categories generally don't have anything to do with the quality of care that you're getting, just the kind of proportion of cost sharing. Commercial plans through insurers often have similar packages to that kind of bronze through platinum situation. It'll just vary on how much cost sharing that you'd be responsible for. And then a little segue into the plan and network types. I know that can get confusing with the many different acronyms. So some plan types will allow you to use almost any doctor or healthcare facility, whereas other ones would be limiting your choices or would charge you more if you use providers outside of their network. So the plans that require referrals are HMO and POS plans. HMO stands for a health maintenance organization. This one is most common to individual plans, so like not through an employer. So this would require a referral for specialists, and you would have to stay in network to have services covered. There's also POS, which stands for point of service. So if you're choosing an HMO or POS plan, typically you're going to have to see your primary care physician before scheduling a procedure or visiting a specialist, which is a reason that a lot of folks tend not to prefer HMO plans as much. But by limiting your choices with providers that your plan has contracted with, HMOs do tend to be on the cheaper side. They're a cheaper type of health plan. One benefit of HMOs and POS plans is that there is just one primary doctor who's managing your overall medical care. So if you have a good relationship with that doctor, that can lead to a greater familiarity with your needs and that continuity of medical records. So if you do, also if you choose a POS plan and go out of network, you'll want to make sure to get a referral from your doctor ahead of time to reduce out-of-pocket costs. In the case of an HMO, you just can't go outside of network and be covered, with some exceptions for emergencies, but for the most part, not. And then for the PPO or EPO, that's either preferred provider organization or exclusive provider organization. These are more commonly employer-based plans. They tend to have a bigger network of providers, and you can go out of the network. The plan would just cover less of that service for out-of-network providers. And you also don't need a referral to see a specialist. So if you would rather see specialists without a referral, then you're probably going to be happier with an EPO or PPO. one note, an EPO, the exclusive provider organization, typically don't require a referral, but some of them do. So that's just, you want to make sure you're reading the fine print. A PPO can often be better for folks who live in remote or rural areas, especially if there's limited access to doctors and care, because that might just kind of force you to go out of network. So I know that's kind of getting into the weeds of things, but that's a basic summary of those options. So it can certainly feel kind of overwhelming trying to figure out which type of plan is going to be the right one for you. There are definitely organizations that are offering assistance out there, some including the Patient Advocate Foundation. So they offer specifically one-on-one case management that can help you decide what health insurance is going to be best for your particular case. So on this slide, I've got some of PHA's online resources. So those are those top two bullets there. The PHA Classroom has a bunch of webinars. We have a specific like insurance and treatment access guide section. And then there's also separately from Classroom, some written guidance online on PHA's website that goes into a bunch of different insurance questions. So those are the links for both of those. And then there's the link there for the Patient Advocate Foundation with their case management. And then also Medicare Rights Center can be useful, especially if you have specific Medicare questions. And I believe Angela is going to pop those into the chat. So we have those available for anyone who wants to click on them and use them right away. I believe we are also going to be able to share the slides from this presentation, so that's an option there as well. So I'll take a pause here just to check out some of the questions that have come through. Let's see. So I see Sherry has asked if PAF is part of PHA. No, they are a totally separate organization, but they do really great work. So I like to share those additional resources out there. PHA is not the only organization doing this kind of work. Andrea asks, I have the most expensive supplemental PPO with United Healthcare, both for medical and separate drug prescription plan. Really, really high drug copays, more than the premium. Says she has a Medigap Plan G. Never been more confused in her life. This is a PPO plan which has done nothing for you, but still need the PPO because you see a lot of specialists. So yeah, that makes a lot of sense. That sounds, yeah, you're definitely not alone there. I am going to get into Medigap just a little bit in like the next slide. So we can see if some of that might help answer a few questions, but it sounds like there's kind of a multi-part question there that has a lot of different components to answer. So I'll go ahead and just jump into some of the Medicare reminders, and then we'll get back to a couple more questions. So last year during open enrollment season, we did a deep dive on Medicare and answered a lot of different questions in that 4-part webinar series that I did with Danielle Burkett. So you can view all 4 of those episodes and also download the FAQ PDF, where I've summarized a lot of the content that we had covered from there. I did want to just go over a few things that came out of that series, just to give folks, you know, an annual reminder of things that either if you didn't catch that series or need a reminder of it. So firstly, Medicare Advantage, which is sometimes referred to as Medicare Part C, that is used instead of original Medicare. So you're getting a plan with a private insurance company, and they provide your hospital or Part A benefits and your outpatient or Part B benefits. So your Medicare Advantage plan does still count as Medicare for the purposes of nonprofit grants and copay cards, that kind of thing, even though you are getting it through a like quote unquote commercial insurance company. It is still counts as Medicare. One other thing to keep in mind, if the Advantage plan that you're using or if you're considering doesn't already offer a Medicare drug coverage portion, then you might not be able to join a separate Medicare like Part D drug coverage plan. The Medicare Advantage is kind of intended to be all-encompassing, but some of the plans don't include drug coverage. So just really make sure that you're doing your homework, and if you are considering an Advantage plan, make sure you know everything that's included in that. Go ahead, Tonya.
Jaeger, there's also a question. Somebody's asking if they could have traditional Medicare A and B and use an Advantage RX plan. I thought that was kind of a timely question.
Yes, I am not super familiar with how that would work. I would imagine that the Advantage RX plan, if it's only for drug coverage, would still be fine to get like original Medicare part like A and B, but then like that would be basically just a Part D plan. And I guess some Part D plans can call themselves Medicare Advantage, but my understanding of it, and I'm by no means like a super advanced Medicare expert, but my understanding is that Medicare Advantage has just the Part A and B and sometimes D wrapped together. So if the plan is only covering Part D, then yes, you should be able to enroll in Medicare Original A and B, I think.
Yeah, probably better to ask the individual if you're looking at a Medicare Advantage prescription policy or D. I would think that you probably would be very astute to give them a call and say, hey, what is the option here? Can I use regular traditional Medicare A and B and still sign up for you? Or does that default to all of my Medicare plan?
Yeah, definitely make sure you're digging more into that, because that is a little bit strange. So something else that folks sometimes get tripped up by, there's the Medicare Advantage plans that we've been talking about, and then there's a Medigap policy. So a Medicare supplemental insurance, also called Medigap, is in addition to original Medicare, rather than being its own full plan like Medicare Advantage. So Medigap and Medicare Advantage are similar in that they are both provided by a private or commercial company, and Medigap is a supplemental policy, so that's helping pay your share of costs for original Medicare. Of course, I will say with the new cap on cost sharing at the catastrophic level that's been introduced just like starting next year with the Inflation Reduction Act, that is probably going to change things a little bit as far as how useful a Medigap policy is. I'll get more into that on the next slide, but I will just kind of flag that. So I just want to note, you can only buy Medigap if you have original Medicare. So you cannot get both Medigap supplemental insurance and Medicare Advantage. Those are kind of an either or situation. So generally you have to sign up for Medicare Part A and Part B before you can buy a Medigap policy. And then you would also be wanting to buy a Part D drug coverage plan separately as well. One thing to note that I don't think really gets talked about enough with Medigap is there is only one open enrollment, quote unquote, period for Medigap per person per lifetime. So this starts the first month that you have Medicare Part B and you are 65 years or older. So this is definitely a different thing than your regular open enrollment, like annual period. For Medigap policies, what they mean by open enrollment is that during the 6-month period, you can enroll in any Medigap policy, and the insurance company cannot deny you coverage due to pre-existing health problems, which is called medical overriding. So after that 6-month period, you can certainly still apply, but it's possible they would be allowed to deny you if you apply for that policy, or it might just end up, costing more. So your Medigap open enrollment policy, like I said, is a one-time enrollment. After those 6 months are up, then medical overriding would apply. Another thing that I think gets really confusing for folks is all the different letters and different plans. So all Medigap policies are standardized. So that means they are offering the same basic benefits. That's regardless of geography of what state you're in, regardless of insurance company. There are 10 different types of Medigap plans that are offered in most states. So not every state is necessarily offering every plan, or maybe not every insurance company is offering all 10 of these different lettered plans. But broadly, the letters are A through D, then F, G, and K through N. So the main difference is the price between plans with the same letter that would be sold by different insurance companies, but they are kind of, if you're comparing a plan F to another plan F, then the price should be the main difference there. I hope that actually helped clear things up and not just make things more confusing. So I will go ahead and check out some questions now. Let's see.
In regards to the financial assistance for prescription drugs, Jaeger will be providing a list later in the talk, and there's also going to be a web link that she's going to share. They are going to share. Sorry.
Thanks. So as far as, let's see, Karen says choosing a plan if you have TAF, which that might be the assistance fund. That's what that acronym makes me think. I don't know if I'm mixing my acronyms up. Should I choose a plan with the lowest monthly premium, Medicare Part D, if my coinsurance and deductible is covered by TAF, the assistance fund, as long as all my drugs are covered?
So I would be leery of going that route, just in case something happens to your assistance. I have had that happen once in my career, where the assistance plan folded, and then it left a lot of patients in a lot of trouble. So I would do what's best for you, but I would be very leery of a plan that, or a thought process that something is being fully covered. You could leave yourself very vulnerable later in the year, unfortunately. Do you have any other thoughts, Jaeger?
I mean, I guess the only thing is mainly just, I know TAF is one of the few that doesn't have a specific dollar amount that they provide in their grant. So that would be kind of the one where you could maybe get away with that. I think your point is still very valid. That is, you've got to weigh those risks against what your financial situation is. But yeah, just kind of looking down the road and seeing how much is actually going to be covered. I will say that's also kind of going to be affected by the changes that are coming through with the Inflation Reduction Act. So we'll get into that a little bit more. And hopefully that's going to make folks feel a little bit more at ease. Let's see. So Phyllis says my out-of-pocket for Plan D Medicare is $400,000. What can you do? So that I guess Tonya, if you have thoughts on that, you're welcome to jump in.
I believe when Phyllis is talking about the out of pocket, and she can maybe type in this, but I'm assuming she's talking about the amount that she pays for the medicine as well as the outlay for the actual Medicare D plan. I think with the Medicare, with the Cost Reduction Act that Jaeger is going to be discussing later, I think that's going to be hugely different. Um, but if you're lumping in the amount that you're paying for the plan, that may be what's hitting you hard. Um, I will say that with the information Jaeger's going to give us in a little bit, it may give you pause and give you reason to just kind of reassess what you're doing with the plan that you're on currently. Don't you think that that's true, Jaeger? Or am I
Yeah.
misreading the question?
I think so. Yeah, I guess Phyllis, if this doesn't feel like it's answering your question, please either, I don't know if you're able to add to your question or just submit a new one. Um, yeah, I think I'll maybe go ahead and just
Oh, Phyllis did say, she said that I'm sorry, she said that the Medicare Plan D is under $100 per month, so that's reasonable. But your Uptravi is what's costing you, and that's $408,000 per year. Again, Jager's got some good news coming for you, so that's a good thing.
why don't I jump into that since we've been
I
teasing it
think you,
so
I
much.
think you need to.
All right. So we'll talk about what is going to be new. So these are the main changes from the Inflation Reduction Act that was passed in August of 2022. And these a bunch of changes are being rolled out over the next like decade or so. But I'm just going to touch on the changes that are actually getting implemented in 2024. And this is coming directly from the like Medicare and You 2024 handbook that I got from the Medicare.gov website. So I feel pretty confident that this is how things are going to play out this year. I know there's been a little bit of legal questioning of like pushback on the Inflation Reduction Act, but it looks like this is going to be implemented this year. So for Medicare, starting January 1st, 2024, if you have Medicare drug coverage Part D and your costs are high enough to reach the catastrophic coverage phase, they are doing away with that 5% copayment or coinsurance in the catastrophic coverage phase. So once you hit the catastrophic coverage phase, there is no more copay or coinsurance. That's it. That's the max that you've are going to have to pay out of pocket for your drug costs. Which I know is like a huge game changer for this community because it takes like nothing for folks to get into the catastrophic coverage phase.
So
So
the catastrophic amount for the year is how much?
I want to say it's,
30.
I would have to, I don't want to say a
I want
number
to,
to be
yeah,
wrong.
it was under $4,000, I believe.
Yeah, that's what I
So
was thinking.
for any of you that are paying a lot of copays for your pill forms of your medications, from the way the new Cost Reduction Act reads, you should be cutting down so that you are only paying a maximum of $4,000 per year. Um, again, once I realized this, I was absolutely amazed and so excited for my patients because I know the amounts, like Phyllis was talking about, are not terribly uncommon. Reasons like that make things like the HealthWell assistance that was $10,000 for the year very, very helpful because that would then get you through what you needed to and then have no copay. Where that doesn't help you is in a lot of cases, Jaeger, your screen just changed.
I think there might have been a connection
Oh, okay.
problem, but that's
So for those of you who are on nebulized treatments, subcutaneous or under the skin treatments or IV treatments, those are actually Part B or major medical plans. And when you get into those are not going to be covered necessarily by the Healthcare Reduction Act. So we're going to see a big shift where a lot of our patients, it was much more reasonable for you to be on IV or sub-Q or inhaled with a nebulizer because your copays or your co-insurance was nothing. And now you're going to see that you're going to have a lot more benefit, I think, if you are on the DPI or the pill forms of medications. You no longer are going to be hit as hard because you're on those medications. So I think if this holds true, this is going to be a huge game changer for all of you. I'm praying that our insurance friends don't find some workaround that's still going to kill us. But that being said, I think that we are going to have a lot of good things coming our way.
So let me see if I can correct the view here. I'm not sure what happened with my internet connection, but it seems to have restarted the presentation. So that's a little odd. Give
Yes,
us just
so
a
the
moment
anonymous
here.
person posted, are all PH drugs subject to the Reduction Act? As far as we know, the answer to that is yes. So yes, Uptravi would max out at $4,000 annually if what we're reading is holding true, which is what we have every hope that that is. I know it seems really strange when you're spending the amount that you're spending currently to believe that that's going to be an option. But I think just the fact that a lot of times you're catastrophic, you are still responsible for 5% per month, it still was a humongous cost for most patients. And so yes, the catastrophic is a great idea, but when you still are responsible for 5% of a very expensive drug, it's not as helpful, unfortunately, as it could be, or as it's hopefully going to be next year, and then subsequent years. I'm sure that in order for those rules to apply, that is going to be a medication that has to go through your insurance. In other words, if there's those of you that are getting, say, tadalafil or sildenafil and using GoodRx, those would not apply towards your out-of-pocket costs. If you are getting them through your insurance, then it would apply for out-of-pocket costs. I hope that's not too terribly confusing.
I think we will probably be needing to provide more guidance as we go along. I will definitely be trying to get in on all the various webinars and information sharing meetings that I can that are going to be providing guidance to organizations to and providers and everyone to kind of pass along to patients. So we're definitely moving into kind of a new era. And I think, like Tonya said, it's certainly possible that with this new ruling, there's, new legislative language that insurance companies have to play around with and figure out possible workarounds. That's never going to go away. They're always going to be looking for ways to reduce their costs, and that's always going to lead to more costs to patients. It's a really uncomfortable game of tug of war. But for right now, for this coming year, this is what we know to be true. So we will, try to share as much information as we get more updates. But yeah, that is actually how it's looking to be.
So Karen, your question of Medicare says you don't pay anything after January. If you're on Uptravi, I will tell you that Jaeger and I went to Medicare.gov yesterday, put in 2 medications. One of them was not Uptravi, but it was another expensive medication. And it did say, it broke it down by months. And it did say that my cost for the first month was whatever. And then February through December had $0 copays listed for both drugs. So it does appear from even their calculator, that is what they're saying.
I do see another question from Kim. Just read on Medicare.gov that the 2024 out-of-pocket spending reaches $8,000, including payments made by others. I believe the payments made by others would include like the amount that Medicare, or if you have a Medicare Advantage, that Advantage plan is paying. So there's that cost sharing portion where you have a certain out-of-pocket responsibility, and then that's kind of being like matched, or whatever the ratio ends up being for your insurance as well. So I think that might be right. And that's part of why I was kind of hesitating to give a specific number, because I have a couple of different numbers floating around in my head. But Kim, I think that, I mean, especially if you're reading it from Medicare.gov, that seems right. And I think that's why there's that difference of the number that Tonya mentioned versus the number that you're seeing would be kind of the total amount that lets you reach that catastrophic level. And then of that total amount, you actually only owe, that certain out-of-pocket amount.
So TW writes, my Tyvaso inhaler versus DPI is free, and that the DPI is $600. That kind of goes back to the nebulized medication really being falling under the Part B or the major medical, and the DPI falling under your drug plan. Unfortunately, it's almost punitive for you to go to DPI for that reason previously. But if the convenience of DPI is worth your putting out to get to the catastrophic, then you may have less of an issue throughout the year. It's really one of those things that you have to weigh benefit versus risk. We've got a question of, if you can't get pill form, what should you do? Unfortunately, there's not a lot of options. If you can't get pill form, it's going to go through your Part B, as in boy, except if certain Advantage plans are actually making your IV, your sub-Q, your inhaled medications go through your drug plan, and then the nursing for the care of that whatever treatment would go through your Part B or your major medical. That's been something new, and the only thread of commonality that I can find is really the fact that it's an Advantage plan. I've not seen a regular Medicare plan that has sent the medication itself go through the drug plan. So it's going to be an interesting time.
Yeah, I think interesting time, and kind of bear with us as we learn new things too are going to be the name of the game as we move forward. Relatedly, I see Karen has included, she's concerned that the online plan comparison for Medicare Part D does not back up what we're saying about the Inflation Reduction Act as of this morning, that it's still showing a payment each quarter, $90,000 in April and again in subsequent quarters. Again, this is one of those, I'm not sure if maybe that website needs to be updated, if like the Inflation Reduction Act changes haven't been implemented yet. I think this is going to be an area where possibly the implementation of these changes might get a little bit messy. So I think you just want to be as in communication with your care team as you can, in communication with your specialty pharmacy. You're probably going to be hearing some conflicting things because we're, like I said, all learning and trying to sort out this honestly very big change together. So as much as you can be doing your own research and looking online, with caution, I would say definitely with caution, because again, different websites are probably going to be saying different things. But yeah, just information gathering, talking to your care team is going to be kind of the way to go. I
Yeah.
also see Kimberly asking, what is TAF? So that's an acronym for an assistance foundation. They have a very straightforward, almost too generic name. It's just the Assistance Fund. That's what TAF stands for. Let's see, a couple other questions here. Let's see. Go back and see if we missed a couple that are higher up. So I see TW is saying, I'm under 75 years old on Social Security or the SSDI with Medicare A and B plus D plans. Does anything change when I turn 65? Does my Medicare or disability SSDI change as well? So that is a great question. That I think is going to be something that you should try to get some help with from your like care team specifically. It is gonna, I think, depend a bit on the specific plans that you have. I think there might be a standard way of like from the shift from disability SSDI into like the age-related SSDI, but yeah, so that is a kind of nuanced question. I will say the case management services from the Patient Advocate Foundation, I believe, are more equipped to answer that kind of thing. So that's an example of one of those kind of getting into the weeds questions that would be good to try with them and see if they can offer some of those answers.
I love the fact that Andrea shared that TAF is open for assistance as of last week. I appreciate and pass those things along to my patients every time I get them. So I appreciate that, Andrea.
I did have a day this week where I had checked in the morning and they were open, and then I checked later that day and they didn't seem to be open. They may not be open anymore, but also funds definitely come open and closed pretty quickly. One really good resource to try to keep tabs on that is called Fund Finder. I don't know if I have a link to that in this presentation. But I know it is linked on PHA's financial assistance part of our website. So
Yeah, I think I can access that too pretty quickly,
okay.
and post it in the chat screen.
But yeah, I will keep moving along just because I've got a couple other slides I want to get through. I guess to continue on with this page, there's a few other things. Obviously, the no copayment with catastrophic coverage is the big headline news, but the extra help program is also expanding. So if you are like right on that border of being able to qualify for extra help, you may now actually qualify. For any folks who have insulin needs, that cost is going down. For all folks on Medicare, adult vaccines are available at no cost as well, so that's helpful. And then for folks getting insurance through the Marketplace Health Exchange, there was some question of those tax credits ending. They are being extended for another 2 years. And then here I just have that link to the Medicare handbook. So I know we are a little bit tight on time, but I did want to turn this over to Tonya to talk a bit about figuring out drug cost and coverage.
So when we're talking about information for drug coverage formularies, you really, really need to do your homework, obviously. You need to actually be really careful though, because there are some websites out there to quote unquote help you, and they are essentially fee sites. So you would actually end up paying for them to quote unquote help you to do something that you could do by yourself. What I would suggest you do, as far as if you're looking at specific insurances, as I said before, the Medicare.gov, unfortunately, while I've always sent my patients there, it is very cumbersome currently. And I think it can be fraught with a lot of challenges. So what I would do is pick a few programs that you think, oh, I might be wanting to do this one. Go into that website. Um, you will need to know specifics. So say if you're looking at Humana, Humana has several subspecialty plans that you really need to know exactly what plan you're looking for. Sadly, they can all be fairly different. And they can say they will cover or have things on formulary that the other Humana plan doesn't. So you really want to look for that specific geographic region, state, and what particularly you're looking at, whether it's an HMO, PPO, or Medicare Advantage. Make sure that you're being very open with your care plan or care team, as I said before. That's imperative so that if you're going forward, as I had a patient call in and say she found out that one of her meds was not covered, um, it was discussed with the specialty pharmacy, and they were able to actually get an override, a formulary override for the entire next year. And that was all because she was proactive. So that's probably one of the biggest takeaways that I can give you is really work on being proactive and letting your team know what your thoughts are. In some cases, they may be able to tell you, oh, well, I have no problem getting X covered with this plan, but this might be a challenge if you're looking at one of the smaller plans. Um, if there's a preferred drug category, a lot of times they will tell you what is the preferred drug. If the one that you're on is not the preferred drug, what is? And your healthcare team may be able to get it approved as a non-formulary option if they know what they're kind of combating. I've had some that have asked patients to try and fail all different therapies from all different types of medications, which is not appropriate. And in those cases, those were time consuming, but very feasible to get the overrides for. Um, again, if your healthcare team can't get the override, be prepared. What am I gonna, what are my options? Um, it's a big challenge to us because there are carve outs for everything. It used to be that patients, if they had Florida Blue, I'm in Florida, or if they had Silver Script, I could tell you who the specialty pharmacy was, um, approximately what your copays were going to be. Now, with all of the little subspecialty plans, we have no idea when it comes to that. Um, the other part of that is you really want to look at your specialty pharmacy. If you are very comfortable with your specialty pharmacy and you're looking at a new plan, it may be that the plan is going to force you to change that pharmacy. So you want to know up front the medicines that you're on, are they available with that new plan, with that new specialty pharmacy? And if not, what is their option? Are they going to send you to, say, 2 or 3 different pharmacies because they can't offer it in one place? So those are kind of things that you want to ask that a savvy person who's had pulmonary hypertension for a few years kind of comes up with and goes, oh, I don't want to change specialty pharmacy. Who is the major medical I need to use so that I can stay with Accredo or CVS? Um, so those are pretty imperative things for you to think about. If you've had problems getting your drugs covered in previous years, and you know that, oh my gosh, they had to go and do an appeal and they had to do a second appeal and they finally got it approved, be aware that in some cases, your insurance approval for a non-formulary drug are not just for a year. A lot of them are for the life of you being on their plan or using that medication. If you decide to change plans, it's likely that you're going to fall into a situation where you're going to have the same pushback from the new pharmacy that you had from the old, or new insurance from the old insurance. And you just, again, want to make sure that you're prepared with either having extra shipments before you change plans or whatever you need to do there.
All right, and I know we are getting tight on time. hopefully folks can stick around for a little bit longer because I know we've got some additional slides to go still, but I'll try to move through them quickly. And so as far as financial assistance, oops, went too far. Our website is pretty great to start with. So that's phassociation.org/help. We do keep that current, very current. So I'm, frequently checking those assistance funds and having our webmaster update them when they come open or when they close up again. There are drug manufacturer assistance programs as well. So those tend to be kind of the two initial branches where if you have a Medicare or otherwise government funded source of insurance, then you're going to be more likely finding success with those nonprofit assistance funds. There are some that do help folks who have commercial insurance, but for the most part, they focus on Medicare folks. And then kind of on the flip side, for the drug manufacturer assistance programs, most manufacturers, just through regulations, are not allowed to help folks who have a government source of insurance. Some are, some have some workarounds, some have like a connected but independent foundation that they can use to assist. So it is still worth looking into both options, regardless of your insurance. But that just kind of gives you a bit of a direction as you're starting.
The other thing is we did have a question earlier, and I just answered it in the chat, but somebody was asking specifically if there was assistance through the manufacturer for generics. In specific, she was asking, I believe, about tadalafil and ambrisentan.
Okay.
And
I do know two specific things for those ones. Tadalafil actually is available on GoodRx. So that is what I generally recommend for folks, both tadalafil and sildenafil. Those two specifically are carried through regular pharmacies, and so you can use a GoodRx coupon, whereas all the other pH drugs, those are too much specialized to go through anything but a specialty pharmacy. So for tadalafil, if you're not on GoodRx, that's a great option. For
so the manufacturer option for the generics is not available.
right.
So that was really kind of my thought process. Unfortunately, if we have someone who loses insurance or has things like that, sometimes we can get help from the brand name manufacturer, but again, that's on a case-by-case basis. But unfortunately for generic, in many cases, our patients pay way more in copay for generic than they did when they were on brand because of the brand manufacturer assistance.
Yeah. Yeah, there are a handful of generics that I think do have some copay assistance. It is definitely like exclusively available to commercially insured folks if you have Medicare. I don't know of any generics that offer those like copay assistance cards. So once you've kind of exhausted those first two options, if all of the nonprofit assistance funds happen to be closed at the time, and if you've already checked out the manufacturer assistance programs and you're not eligible for them, that's the point at which you should reconnect with your specialty pharmacy and kind of lay all of that out very clearly, stating what you've already done, let them know kind of how much medication you have left. It's really, especially if you're getting close to the end of your supply and you're not necessarily going to be able to afford the next copay. All of those key details are kind of check boxes that will prompt your specialty pharmacy to transfer you over to their assistance. It's not something that they typically volunteer. You kind of have to know to ask for it, but that is potentially an option.
And I tell all of my patients to ask. They will not offer it up front, but the minute you say, "Wow, that's a lot, I can't afford that," that's what triggers them to say, "Oh, well, let me see what I can do to help." It's been a burr in my side since day one that they won't just offer it up front for our patients, but do definitely get vocal with them and say, "Hey, there's no way I can do that. What other options do we have?"
And then here are a couple of other links for folks to check out. I think I had already pretty much, I think we shared the link to just the insurance guide. That's all that this is. Then this is the insurance at pageassociation.org is an email that comes to my inbox. So if you have questions and want to send me any questions, you can email me there or call that number. And then I believe we had already shared this as well, but the Medicare Rights Center is a pretty helpful organization that just has a lot of resources on there. And then for folks who are not with Medicare but have the marketplace insurance, healthcare.gov is where you want to go for that. So those are the main ones. Just real quick, an additional reminder, we'll end where we started with the open enrollment dates. So marketplace health insurance, that's November 1st through December 15th. There's a lot of extensions after December 15th. For Medicare, that already started October 15th, ends December 7th. You do have a little bit of a grace period, especially with Medicare Advantage plans for the first 3 months of the new year. And then with commercial plans, make sure you're checking with your HR department. I did have a couple of questions that we had answered from like the pre-submitted questions. So I wanted to at least get through those because I know we are already over time. But real quickly, someone had asked about the California Med-Cal, what is spend down? Spend down is also known as the share of cost. It's very similar to an out-of-pocket deductible. Someone had asked whether you can get Medicare if you have SSI but don't qualify for SSDI. Generally, no. If you have SSI, then you're going to be receiving Medicaid insurance. If you don't qualify for SSDI, then you would not be eligible for Medicare until you turn 65. As far as new therapies, with the, particularly in regards to how much is it going to cost, is there going to be assistance? There's no real way to know the specifics about costs until we get the FDA approval. Until then, that's kind of what the insurance companies and pharmaceuticals are going to base their pricing on, is that FDA approval. And then as far as the Medicare coverage of portable oxygen concentrators, that is a big topic. I'm going to try to follow up on some of these questions that we've gotten because folks have been sending in a lot of really great ones. And I know there's a big need and interest for this kind of thing. So I'll try to follow up and answer some of the questions that we didn't get to in a follow-up email. But briefly, Tonya, if you want to talk about the portable oxygen concentrator.
Well, I'll talk about that, but I also want to talk about Kim's question about GoodRx coupon, them charging her more for Tadalafil than the coupon. When you are on GoodRx, you need to look for Tadalafil PAH. It's a specific NDC. It's a specific, basically, barcode for that particular pill. Even though it's the exact same dose as for erectile dysfunction, they are two entirely different charge codes. So what you're looking for when you're using GoodRx is for them to really to say GoodRx, Tadalafil, PAH. If you're on 2 tablets a day, of course, it's 60 per month or 180 per 90 days. So hopefully that kind of clears it up a little bit. It sucks that they charge us more for pulmonary hypertension than they do for erectile dysfunction, when you and I both know it's essentially the same drug, but that's unfortunately the way the FDA approved them, as two different codes. So progress on the Medicare covering POCs. I have actually had some success in Medicare covering. They are very, very specific. So I would definitely call your home oxygen company first and ask them if with them, if you're eligible for a POC to be covered by your insurance. The success that I've had have been people that were less than halfway into their 3-year commitment. And of course, obviously needing a certain liter flow that that way, that would be supplemented by the POC, because portable concentrators will only provide a certain amount of oxygen supplementation. So I know that's not what everybody wants to hear, but at least there's some forward movement. 3 years ago, I could tell you that there was no forward movement. So a little something is better than nothing. So that's a good thing. And I do agree that Mark Cuban's Cost Plus can be very helpful as well. Our transplant team uses that a lot.
Right. So I hate to cut us off because I know there's so many good questions on here. Like I said, we will definitely follow up and try to share slides in the recap kind of summary email that all of you who have registered are receiving. So thank you all for tuning in today. I know it's a big topic, so we did our best to cover what we can. Big thank you to Tonya for being here and sharing so much of your expertise. And
Well, thank you for having me, and I am available. You can always reach out to Jaeger and she can pass along to me, or we can kind of go from there.
Awesome. All right. Thanks, everybody.
Thank you. Bye.